Thank you. All right, so welcome everyone. My name is Sarah Nolan, and we're pleased that you could all join us today for this week's lecture in Volume 6 of the No Neuropsychology Didactic Series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsor for their continued financial support for the series. And we're excited that you're here today for the live talk and discussion. And as a reminder, for all our talks are recorded and are accessible on our YouTube channel. Before we start, we want to make sure that you have the disclaimers for the series and that this training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted through the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now, it's my pleasure to present our speaker for today, Dr. Calliope Nagari. She's going to be talking to us about neuropsychology and cardiovascular function surgery. All right. So she's a researcher, a postdoctoral researcher at Aristotle University of Thessaloniki, Greece, and adjunct lecturer at University of Western Macedonia in Florina, Greece. She holds undergraduate degrees in nursing and psychology, as well as a master's and a PhD in neuropsychology from Aristotle University of Thessaloniki. She has experience working with patients who have neurological, psychiatric, and cognitive disorders, as well as chronic disease patients suffering from cancer and cardiovascular diseases. She's the head of the Center of Creative Activities of Children and Adults with Disabilities, and she also works as a counseling psychologist in Prison Diavada, Thessaloniki at the School of Second Chance. Currently, she is a global membership committee member of International Neuropsychological Society and leader of rehabilitation of COVID-19 patients working group from NeuroCovid from the INS Task Force SIG. In addition, she is the General Secretary of the Board of Directors of the Hellenic Neuropsychological Society and Ethics Committee, and also the President of the Society. She is committed to leadership skills and issues of equity, diversity, and inclusion in her clinical and research work, and we're so happy that you joined us today. Go ahead and take it away.
Thank you, Sarah, for your nice presentation of me. I'm very happy to be here with you today. I'm honored by your invitation, and I'm a huge fan of your work. So I'm very happy to be here with you. Now, let me share my presentation. Okay, I will speak about neuropsychology and cardiovascular function surgery, as you said. But before I start with my presentation, let me introduce myself and my city. I am Dr. Calliope Nagari, postdoctoral researcher at the Lab of Cognitive Neuroscience, School of Psychology at Aristotle University of Thessaloniki in Greece. I'm a lecturer and program leader of postgraduate program in clinical psychology at City College, University of York, Europe campus. I'm an adjunct lecturer at University of West Macedonia in Florina, Greece. I'm the head of the Center of Creative Activities of Children with Disabilities, Municipality of Kalamaria in Thessaloniki, Greece. I was a counseling psychologist at prison of Thessaloniki Diavata at the School of Second Chance. I was a research fellow at University General Hospital of Thessaloniki, AHEPA, at the Department of Cardiothoracic Surgery. I'm editor-in-chief of Journal of Psychiatry and Mental Health, and I'm a general secretary of Board of Directors and Ethics Committee coordinator of Hellenic Neuropsychological Society. Now, let me introduce my city, Thessaloniki. Thessaloniki is the second largest city in Greece. Its nickname is the co-capital, a reference to its historical status or co-reigning city of the Eastern Roman Byzantine Empire, alongside Constantinople. Thessaloniki is Greece's second major economic, industrial, commercial, and political center. It's a major transportation hub for Greece and Southeastern Europe, notably through the port of Thessaloniki. The city is renowned for its festivals, events, and vibrant cultural life in general, and is considered to be Greece's cultural capital. This is my city, Thessaloniki. You should come when you have the chance. And these are some of the historical monuments of the city, which are by the sea. Now, let me introduce AHEPA University Hospital, which is the hospital that my research took place and was also the first reference hospital for COVID-19 patients in Greece. AHEPA Hospital is considered one of the biggest hospitals in Greece, based in Thessaloniki. Covers 680 beds and all the spectrum of medical and surgical specialties of medicine, as well as the psychiatric sector. It's associated with the fourth health district of Health Service Macedonia and Thrace as an independent service with administrative and economic autonomy. The central service of AHEPA Hospital is located in the territory of Aristotle University of Thessaloniki within the administrative region of the municipality of Thessaloniki. It's a major teaching hospital and part of the national healthcare system of Greece. And this is me working in the Department of Cardiothoracic Surgery. Now, about my research. Heart dysfunction leads to dysfunction of the brain according to research. Coronary artery disease is the most common type of heart disease. The major blood vessels that supply the heart, the coronary arteries, struggle to send enough blood, oxygen, and nutrients to the heart muscle. Cholesterol deposits, plaques, and the heart arteries and inflammation are usually the cause of coronary artery disease. Sometimes the first sign of coronary artery disease is a heart attack. And the neuropsychological sequelae of the cardiac arrest is the abrupt loss of cardiac function and circulation, followed by loss of consciousness. Acute myocardial infarction is the result of acute coronary ischemia and necrosis. Moderate to severe neuropsychological sequelae of out-of-hospital cardiac arrest are still present in approximately 1/2 of the survivors at 1 year and may be permanent. There seems to be no excess of increased disability in the subgroup of patients with delayed advanced life support. The most common pattern of impairment, of neuropsychological impairment in patients was a combination of memory and motor deficits with variable executive impairment. Diffuse sudden ischemic hypoxic injury caused by cardiac arrest does not preferentially damage memory systems. Subacute or stepwise hypoxic or exotoxic injury may cause isolated hippocampal injury and amnesia. The common pattern of impairment in the post-acute phase after cardiac arrest is in combination of memory and subtle motor and variable executive deficits. From a neuropsychological point of view, cognitive impairment and emotional problems are common post-arrest, and cognitive impairment has been observed in about half of survivors with impairment in memory, executive functions, or processing speed. These cognitive domains are often impaired post-arrest, but also the most commonly assessed. Other scientists and researchers have reported that language and visual constructive functions may be affected as well. Brain damage is often diffuse with multiple atrophic areas due to transient global cerebral ischemia. And along with the cognitive impairment, there are emotional problems as well. There are symptoms of depression and can be found and have been found in 14 to 45% of all survivors. Anxiety was found in 13 to 61% of the patients, and post-traumatic stress in 19 to 75% of patients. Fatigue is closely related to cognitive and emotional function and has been reported in 69% of survivors. Now, the neuropsychological outcome in cardiac surgery patients. Coronary artery bypass grafting is a surgical procedure for the treatment of coronary artery disease. is a surgical procedure that provides complete revascularization, has low mortality rates, but has side effects such as permanent vascular cerebral stroke, systemic inflammation, renal and pulmonary complications, and all these have adverse impact on cognitive functions. The post-operative cognitive dysfunction is generally characterized as impairment in attention, recognition, orientation, memory, and learning following surgery. As you can see, all main and major cognitive functions are impaired. Results in increased morbidity and mortality, prolonged hospitalization, increased healthcare costs, and may have an adverse impact on social functioning and quality of life of the patients. Neuropsychometric tests are needed to detect and quantify sub-POCD, and there is no other way of detecting it. While its incidence depends on the type of the surgery, the patient's age, the method of detection, the preoperative level of education, other coexisting diseases, and the preoperative cognitive performance of the patient. The incidence of POCD following cardiac surgery can be detected in up to 80% of patients during their hospital stay. That means that it's present about 1 week to 10 days after surgery. Is still present in as many as 42% 3 to 5 years later. Following non-cardiac surgery, the incidence of POCD appears to be much lower. The short-term incidence after general surgery is 25.8%, while its longer-term incidence is 9.9% at 3 months and 1% at 2 years. The coronary artery bypass grafting, what are the major consequences from a neuropsychologist point of view? This is the publication we had with the cardiac surgeons and the cardioanesthesiologist. It was the first publication reporting the results of our patients. And it was very important, the collaboration between me, a neuropsychologist, and cardiac surgeons, a cardioanesthesiologist, and technician of extracorporeal circulation systems. Our hypothesis: we examined whether patients undergoing coronary artery bypass grafting with the MEAC system exhibited post-operative cognitive decline to a lesser extent than patients undergoing coronary artery bypass grafting with the CAC system. The MEAC system, these are the MEAC systems, is the minimally invasive extracorporeal circulation systems. It's a new technology, is less impaired because less cognitive decline for the patients, as new technology is less invasive, while the conventional systems are old systems, are used many years ago for the treatment of the patients, is the conventional technology. So the MEAC technology is the innovative technology, the new technology, and the CAC systems are the old technology. And we compared these two technologies. Our method, we had neurocognitive evaluation of 60 patients, 29 operated on MEAC systems, and 31 operated on CAC systems. The patients were tested before surgery, prior to discharge, and at 3-month follow-up. We used alternative forms of tests, and we had also an assessment of anxiety, depression, positive and negative mood as well, because neuropsychological function can be affected by a patient's mood state. This is the neurocognitive test battery that we have used. As you can see, we had a broad assessment of all cognitive functions, as well as emotions too, depression, anxiety, and positive and negative mood. Now, our results, we used 2 × 3 ANOVA mixed design. No statistically significant differences were observed between the two study groups in age and years of education, any of the preoperative cognitive domains, and mood, anxiety, and depression variables, and in medical variables such as the CPP time, the cardiopulmonary bypass time, the numbers of operated grafts, and the intensive care unit stay. With this graph, you can see the performance of the patients in the two study groups. As you can see, before surgery, the performance of the patients of the two groups were almost at the same level. But after surgery, 1 week after surgery, the performance of CAG patients was decreased to a major extent, and the performance of the MIEC patients was decreased to a lesser extent compared to the CAG group. 3 months after surgery, patients' performance on MIEC group was increased, while the performance of CAG patients was stable compared with the second time point. We have the 3 time points: the pre-surgical, the pre-operative, the post-operative, 1 week after surgery, and 3 months after surgery. And these are the statistically significant differences between the two study groups. The same performance, then the same profile can be found on attention and executive functions as well. We had a slightly decreased performance on MIEC group and a decreased performance on CAG group, while on MEC group, the performance of the patients was increased at the third time point, and the performance of the CAG patients was stable compared to the second time point. Now, let's see the percentage of post-operative cognitive dysfunction. In MIEC group, 41% of patients had cognitive dysfunction prior to discharge 1 week after surgery. 21% of patients had cognitive decline 3 months after surgery. As you see, the performance of the decline of the patients was decreased. And in CAG group, the 65% of patients prior to discharge exhibited post-operative cognitive dysfunction, while the percentage was 71% at 3 months after surgery. Here, as you can see, the percentage of cognitive dysfunction has been increased in this study group. Now, our conclusions. What do we have to say about these patients? What we have to say about these patients? In MIEC group, the follow-on performance of the patients exceeded the preoperative neurocognitive levels. This means less overall post-operative cognitive dysfunction in this study group. And in CAG patients, the patients didn't reach operative neurocognitive levels immediately and 3 months after surgery. And this means more cognitive decline on most neuropsychological domains. Our findings suggest that the use of MIEC systems may be beneficial for the neurocognitive outcome of the patients. And cognitive stability is very significant and plays a significant role in quality of life and daily activities, especially in heart surgery elderly patients. And our findings are very important regarding the patient's treatment for their participation in rehabilitation programs. And now let's see another category of heart surgery patients, the left ventricular assist devices patients. Heart failure is a condition that the cardiac output is insufficient to meet the needs of the body, and ischemic cardiomyopathy is a major cause of heart failure. There is dysfunction of the heart muscle and has been previously associated with neurocognitive deficits, among other medical conditions. The left ventricular assist devices have been used successfully in treating patients with heart failure as a bridge to transplant and as destination therapy. A destination therapy means that it's a more permanent condition. And the patients must have the LVADs for the rest of his or her life. The LVADs and stem cells, it's a worldwide innovation in heart surgery and was conducted at a HEPA hospital for the very first time. And the HEPA hospital, as I have told you, is affiliated with Aristotle University. And this procedure in end-stage ischemic heart failure enhances myocardial reperfusion. And this is something that have neuropsychological sequelae. This is the LVADs. This is the devices that are implanted in the patient's heart. And these are the batteries. You can see the batteries of the LVADs. The batteries is inside the bag, and the patient must carry always the batteries with him or with her, because if the battery is not fully charged, his heart or her heart, the patient's heart, will stop. So it's very important for the patient to have the batteries fully charged. And this is the stem cells injection. The stem cells are injected intramyocardially. And this is a photo taken from the operation room. And you can see the injection of the stem cells to the patient. Now, let's see our case study, our patient. I am a 64-year-old right-handed male with 9 years of education. He was married with 2 adult children. He worked as an accountant in private sector. He was retired at the time of the assessment. He had end-stage ischemic cardiomyopathy and was undergoing LVAD and stem cell implant. He followed over the course of 1 year after surgery to determine potential for improvement in condition. He underwent a comprehensive neuropsychological assessment, and he had concurrent counseling sessions with his family, with the neuropsychologist, with me. And his neurocognitive assessment, I assessed this patient before surgery at 1, 6, and 12-month follow-up 4 times. We used alternative forms of neuropsychological tests, and we had an assessment of anxiety, depression, positive and negative mood, as well as quality of life, as performance on neuropsychological tests may be influenced by the patient's mood state. And it was important to assess emotion and emotional status as well. This is the neurocognitive test battery that we have used. As you can see, we assessed a broad range of cognitive functions. We have a very extended battery, and we also assessed the patient's emotion and quality of life as well. And we defined cognitive decline as a decrease of 1 standard deviation or more in performance on 1 or more of the neuropsychological tests relative to Greek normative data of individuals in the same age group and educational level as the patient. The criterion of 1 standard deviation is generally used in the literature. And we compare the performance of the patient, of the same patient at 4 time points. And in the graph, you can see the performance of the patient compared to the average range. As you see, before surgery, patient performance He had no changes compared to the average range, but 1 month after surgery, his performance decreased, statistically significant. At 6 months after surgery, the performance of the patient was increased and reached the level of the average range and remained stable at 1 year follow-up. The performance of the patient was stable compared to 6 months performance. On attention, the performance of the patient dropped, was decreased 1 month after surgery in comparison to the average rates, and the performance was still decreasing 6 months after surgery. But 1 year after surgery, the patient has increased performance and reaching the preoperative levels of assessment. On semantic verbal fluency, as you can see by the graph, the performance of the patient 1 year after surgery was increased significantly because the performance was below above 1 standard deviation compared with the average range. So he had an increased performance. In other cognitive domains, the patient's performance was in the average range with no evidence of dysfunction or decline on the 3 follow-up evaluations. On executive functions, visual spatial perception, visual organization, attention, picture naming, working memory, and mood scales. He didn't have changes in his emotional status and his quality of life. His quality of life and emotional status was stable. And our conclusions, what do we say about this patient? The post-operative cognitive decline at 1 and 6 months after surgery of this patient reversed over time. And overall improvements from follow-up at 1 month to follow-up at 6 months occurred on 50% of the variables examined. The patient's performance returned to the average and high average range 12 months after surgery. And this was very important for the patient because he was able to follow a rehabilitation and cognitive rehabilitation program. And these are our recommendations for this patient. Cognitive rehabilitation program focused on specific difficulties to help a patient to develop new strategies for his daily activities. Psychoeducational programs for the patient and his family. He had management of negative emotions regarding device noise because patient complained about the noise of the device. And he once told me that the noise is like a broken refrigerator, and I feel inside me that I have a broken refrigerator inside me and inside my head and my ears, and it was very disturbing for the patient, and he had to manage the negative emotion regarding this. The patient had psychological counseling and his family as well, together or separately, and this was our recommendation. The important key points for this patient was that he had many counseling sessions before surgery, after surgery, and concurrent sessions with him and his family members. And counseling psychology facilitates a neuropsychological assessment as well. And our research was awarded. We received several awards and we are very proud of it. And we had received awards by Psychogenic Cardiovascular Disease Conference in 2010, the European Association of Cardiothoracic Anesthesiologists, at the 5th International Congress on Brain and Behavior of the International Society on Brain and Behavior, and 18th Thessaloniki Conference of the Southeast European Society for Neurology and Psychiatry in 2011. I received a distinction medal prize from Aristotle University of Thessaloniki distinctions for 2010 and 2011, given to the most distinguished students, undergraduates and postgraduates and PhD candidates. I had a grant from Psychological Society of Northern Greece. I had the grant of Psychological support for PhD candidates, and we received another award at 2017 from the 22nd Pan-Hellenic Anesthesiology Conference. And this is very important to stress that neuropsychologists play a very important role for the treatment of the patients, and the contribution of neuropsychologists in cardiac surgery patients is very important. And neuropsychological evaluation and assessment must be the standard procedure for the cardiac surgery patients, along with the physical examination and medical examinations before surgery and after surgery. And this is very important for these patients to have counseling sessions, many counseling sessions as well, in order to be helpful for their treatment. And we conclude by rephrasing what Alan Badley had told about memory. And we say that perhaps the best way to appreciate the importance of cognitive system is to consider what it would be like to live without it, as cognitive system is not a single organ like the heart or liver, but an alliance of systems that work together, allowing us to learn from the past and predict the future. Thank you for your attention. And this is my email. If you have any questions, I would be very happy to answer all of your questions. Thank you very much.
All right, thank you. So if anyone has any questions, you're welcome to put them in the Q&A box. If just your little tab at the bottom of your screen, and enter your questions there, and then I will present them. So you're welcome to do that. We'll get started with a few of my questions as well. So I appreciate how you went through the different surgeries and everything. I was wondering, as far as, if you were to have a heart condition and need surgery of some variety, is there certain risk factors going into it that are particularly poor for cognitive outcomes? I mean, besides like frank diagnoses of dementia already and things like that.
Many medical conditions are means poor prognosis for the brain as well, like diabetes or smoking or things like that, and not exercising. The patient, if the patient is not exercising at all, means bad prognosis for neuropsychological health as well, as far as I have researched. These patients. So if the patient follow the medication and loses weight and stops smoking, this means health for the brain as well. And it's very important for the patients.
I feel like that's a constant thing. I feel like I say all the time to stop smoking, exercise. Those things are constantly on our lips.
And Sarah, it's your question is very important because I want to stress out the cardiac rehabilitation programs as well, because there are programs regarding neurocognitive rehabilitation, psychological rehabilitation with counseling session, psychoeducational program, and I conduct all a holistic approach for the patient in order not only neuropsychological assessment and neurocognitive rehabilitation, but psychoeducational program as well, and counseling sessions. It's very important, the counseling psychology sessions for the patient and their families as well.
Yeah, agreed. And it's great to involve the families too, because
yes,
patients need help at home.
Okay.
So what would you say is your biggest piece of advice for a neuropsychologist practicing in an integrated care medical team?
In cardiac surgery or another department?
You can do it specific to cardiac surgery or just generally integrating with other sorts of teams.
Well, I like your questions, Sarah. Well, it's very important for neuropsychologists to collaborate with medical doctors, and I have the pleasure and happiness to collaborate with great cardiac surgeons like Kyriakos Anastasiadis in Greece, is the president of the Department of Life Sciences in Aristotle University of Thessaloniki, and he was the chief cardiac surgeon in the team, along with cardioanesthesiologists and technicians of extracorporeal circulation machines. And it's very important for neuropsychologists to be involved in the procedures, because the first thing I did collaborating with cardiac surgeons was to learn cardiac surgery. And I had to be educated, theoretically educated. I didn't go inside the surgery and operate the patients, of course, but I went inside, I visited the operational room, for counseling sessions. And the last patient, our case study with heart failure, I had to go inside the operation room and conduct counseling sessions with him, because he was in need for a psychological treatment and counseling sessions and treatment. So it's very important for neuropsychologists, if they want to be involved in cardiac surgery, to learn the background, the theoretical background of cardiac surgery, to learn major and main things about cardiac surgery patients, because they have many concerns. These patients have many concerns and many deficits as well after surgery. And after surgery is a crucial period for them. So it's very important to have the educational, theoretical background of these patients.
Yeah, that's a really good point. Yeah, kind of, and especially talking to other medical providers, being able to speak the same language and know the same terms, and be able to kind of, they explain to the patient, but you can also explain to the patient.
Yes, conducting psychoeducational programs. Yeah. I had the skills because I was educated in cardiac surgery, and I have learned cardiac surgery, the theory, of course, and it was a challenge for me.
So tell me a little bit about how you got to where you are, and like all the steps in your training, and how you kind of ended up being interested in this, and how you got to the point where you are today.
I like your questions, as I told you. Well, I started being involved in cardiac surgery department for my postgraduate program, for my dissertation, for my postgraduate thesis. And I got involved because I started collecting data, and I started had sessions, neuropsychological assessment from these patients, and I started the collaboration with cardiac surgeons and cardiac anesthesiologists. And cardiac surgeons was very interested in me and my work and the whole procedure. I mean, in Greece and in Europe as well. In Greece, I'm the only psychologist to be involved in a cardiac surgery department. At least I was the only one a few years ago. I don't know if something has changed, but I was the only psychologist who had to deal with cardiac surgery patients from a neuropsychological perspective. I mean, there are psychologists who conduct sessions, counseling sessions, or psychotherapeutic sessions with cardiac surgery patients, not in MEC comparing to CAC, not in these different systems of operating patients, but I was the only one conducted neuropsychological assessment in Greece.
Mm.
So it's very important for neuropsychologists to be involved in cardiac surgery, to be involved in departments of cardiothoracic surgery. And it would be very interesting if some colleagues from other countries can can tell us today if they know some neuropsychologist that is involved in cardiac surgery department. I would be very glad to hear this.
Well, I'll let you know if someone mentions it in the
Yes,
Q&A.
let me know. I'm interested in learning and exchanging experiences with someone else.
Yeah, awesome. So I have a question from one of our attendees. So given that cognitively normal individuals commonly have scores below 1 standard deviation, selecting this cutoff wouldn't significantly increase the risk of false positives of cognitive deficits in patients undergoing cardiac surgery. So basically the question, it was kind of long, so I'll kind of rephrase. So basically selecting a cutoff, since they're performing more poorly, then what would be a good way to prevent false positives?
Well, you see, there are two criteria in the literature regarding the definition of cognitive impairment. And the one is the one we have used, the one standard deviation criterion. And the second criterion is the 20% criterion. That means that if the performance of the patient drops 20%, comparing with pre-surgical levels, that means that the patient has a post-operative cognitive decline. There are pros and cons in the two criterion, but in the literature, these are the more common criterion used to define cognitive decline. I don't know if I answered the question.
Yeah, I think a better understanding of the cutoffs and stuff like that is useful. Thank you.
Yes, this is the criteria. I mean, it's a bit strict criterion because in other situations, they use the two standard deviation, criterion. But in cardiac surgery, research and international literature suggest one standard deviation criterion. So I have used this criterion because it is suggested mainly in the literature. That's the reason.
Yeah, that's a good reason.
Yes, of course.
So we have another question. So this person is interested in the sound of the device in the case study that was distressing for the patient. So what kind of advice or recommendations did you give that patient to compensate for this and decrease their level of distress?
Yes, then I will give advice regarding psychological meditation or some relaxation techniques. Maybe he could try some yoga techniques and maybe some other techniques regarding cognitive behavioral techniques, like managing his thoughts about and his emotions about the device. And when the patient progresses and had this device for a long time, it gets used to it. So it's not a problem anymore. The problem was for the very first moments and the very first days. And then he got used to it, I think.
Yeah. Yeah, that's
Yeah.
it's, I'm sure alarming at the beginning, but it's good that it
Yes,
kind of
it's
habituated you.
destructive.
Yeah, that's good. We also had another person say that they also see patients with heart failure and transplant programs that have the same sort of problems, and that
Mhm.
patients and families need that ongoing education and support, like you were talking about. Um, and so I guess my question and follow up to they're just saying like, yes, I see this too. But I was also wondering, as far as like do you work with people who do the transplants as well?
With the cardiac surgeons, you
Yeah.
mean?
Yeah.
Yes, yes, of course.
Okay.
But I
That's what I was
collaborate, not, I don't conduct counseling sessions with them. I
okay.
collaborate with them.
Okay. So I was just wondering if it was different with having like and putting a device in and stuff like that, if that varied a lot from the heart transplant patients and how they respond.
How the medical professions respond or the patients respond.
Well, worked with some people who've had like lung transplants and stuff, and having a different person's organ in your body can sometimes be very alarming for people. Versus
Yes,
maybe having just a device, maybe a different reaction.
yes, it's a difficult situation, and the patient must be trained and follow and educational, psychoeducational programs. And I was wondering, I had attended many conferences regarding cardiac surgery and LVAD, because it was the first who invented these devices. I think his name was Jarvik. And I attend a symposium about Jarvik, and he was telling that he was a presenter. I remember that he was a presenter and telling us that without these devices, the patient would never survive from 1 day to 1 month to 6 months. He was a survival matter for the patient. And the less problem of the patient is the noise of the device, because it's a matter of survivor. It's a matter of survival. They are survivors and they have to survive. And they need these devices because they cannot survive otherwise without the device. So it's important, and the noise and all stuff are not the main problems
Yeah.
here.
Yeah, survival is definitely a good motivating
Yes,
factor for sure.
yes.
Um,
Of course, there are many concerns about these patients. They have many problems regarding the pain after surgery, and it's important for the nurses to be involved. And nurses of HEPA Hospital was very helpful, and they provided the help, much help to me, because it's a teamwork. I mean, I couldn't have made it without the other professionals, the medical professionals. It's a difficult department, the Department of Cardiothoracic Surgery. It's a very difficult department. They have many difficulties, and it's a team. It's definitely a teamwork. Neuropsychology and the other medical professionals as well.
yeah. So it sounds like you did a lot of learning on your own to kind of get integrated into this sphere that was new
Yes,
to you.
yes.
So for other people who may be interested, like trainees who are interested in this area, do you have any specific reading resources or other resources to get them started to learn about this?
Yes, I can share my research. I have published research regarding cardiac surgery patients and their quality of life. So if they type my name on Google Scholar, they can find my publications. And it's very important to know the psychological, not only the neuropsychological part, but also the counseling part, the general psychological part, because the emotions play a very important role for these patients. And we have alteration of emotions after surgery, because there are many negative emotions regarding the procedure and all this. It's a main procedure. Patients have to stay 2 days in the intensive care unit. It's a standard procedure. For the patient, they have to stay 2 days in the intensive care unit and then go to the department of cardiothoracic surgery. And it's very stressful for the patients. All this procedure, they have pain, and psychologists play a very important role in this all this procedure and all these conditions and situation and emotions that a patient has to face.
Yeah, and what about learning, like, the kind of the nuts and bolts of the surgeries and like what the different devices are and that sort of stuff? Do you have anything to get people started on that?
There are some major books, but they are in Greek. I don't know.
Okay.
I will provide them if they
Yeah, if you know them off the top of your head, you're welcome
I
to
will
say
be
them.
happy to
We
provide.
might have people who are,
I think
Greek speakers.
some main cardiac surgery, they don't need to learn many things about cardiac surgery. They don't have to be cardiac surgeons, of course, but they have to learn the principles of cardiac surgery, like the coronary artery disease, the causes, the treatment, and things like that. I say to other colleagues, to my other colleagues, that I'm a theoretical cardiac surgeon. I don't perform surgeries, but theoretically, I have the knowledge because I had to learn and study. And if they study basic principles of cardiac surgery, I think they will learn many things about the treatment of these patients.
Yeah, I love that title, theoretical.
Theoretical cardiac surgeon.
So we have a question about difference in outcomes, so the cognitive outcomes of different types of heart surgery, so like the CABG, the heart valve repair, replacement, all those different things. Are there major differences in the cognitive outcomes?
Well, I didn't examine too much valve replacement patients. I don't know many things about valve patients, but there are standard procedures about this situation, and I expect for these patients, comparing with the coronary artery disease patients, to have a cognitive decline as well. I mean, maybe to a lesser extent. We cannot be sure because I didn't I had the chance to assess such kind of cardiac surgery patients, but I expect to have cognitive decline for these patients to have cognitive decline as well, because it's a surgical procedure. And this procedure with the surgery and the anesthesiologist part and the anesthesia part has many effects on the brain. So I expect for this patient to have a decline as well.
So would you say that the type of decline, like are there different profiles kind of for different surgeries or different domains that may be more or less affected in different kinds of patients and which surgeries that they do?
Well, as I have told you, as I have presented, there are the MIEC systems, the minimally invasive extracorporeal circulation systems that are less invasive. So this means that these patients can have a better outcome. The patients undergone a cardiac surgery with these systems may have a beneficial outcome compared to other operational techniques. And I expect for this patient, minimally invasive techniques regarding surgery means less cognitive decline as well. And I expect that people operated on this technology will have less decline and better health of the brain. And I expect this outcome.
Yeah, the less you go in and mess with, the better cognitive outcomes.
Yes,
that makes sense.
Yes, of course, there are a lot of factors involved here. The age of the patient, the coexisting diseases, as I have told you, but minimally invasive systems are innovative system and are less invasive. So this is good for the patient. And the operation lasts fewer hours compared to the other techniques.
Awesome. So we have another question about what are the most commonly affected cognitive domains after
Oh,
heart
yes, yes, the
surgery and
domain.
post-surgery? Yeah.
I mean, literature says and suggests that memory is a function that is affected mostly, and executive functions as well, because frontal lobes functions are very important. And I think memory and executive functions, as my research stresses, are the domains that are mostly affected.
Okay, great. Thank you. And what about, further out past surgery, like a year, 5 years? Have most of those gone away or improved, or there's some cognitive domains that are still affected later?
Surgery, general surgery, past general surgery, or cardiac surgery.
That's the cardiac surgery specifically. Yeah.
If the patient had another surgery 5 years ago, for example,
Yeah.
it would be more affected, of course.
So
It's additional decline.
is the outcome generally, much improved a year, 5 years later?
Yes,
They
yes,
had like,
it's improved. But if the patient has another surgery, another cardiac surgery, his condition will be decreased as well. He or she will be affected.
Yeah, so kind of like a cumulative.
Yes, it's additional burden. It's kind of
Yeah.
additional burden
Yeah,
for the patient.
Yeah. All right. So I'm from America, and we have some viewers who are from America who are a little curious about what the training is like to become a neuropsychologist in Greece, just to kind of see if it's similar or how it varies from in America.
Well, interesting question. You need to attend and continue a postgraduate program in clinical neuropsychology in order to be a clinical neuropsychologist. So you need to have a postgraduate degree to be a neuropsychologist.
So how much of your time, like during school, like how much do you do like clinical rotations and things like that? Like how many years are you doing that sort of stuff?
Well, as a student, a postgraduate student, I had clinical practicum as well, and I had research practicum. I had to be in a hospital to be trained as a neuropsychologist, but I had to be in a research protocol with some supervisor professors. So it was very important to follow the two parts, the clinical part and the research part.
Yeah, that
It
sounds
was
very
interconnected.
similar to what I do.
Really?
Yeah.
That's true. And I had a specialty in cardiac surgery because I was trained in the Department of Cardiothoracic Surgery. So I had an additional specialty.
Yeah, that's really interesting to have that additional kind of add-on to it. That's cool.
Any colleagues from cardiac surgery departments in the US or in Europe? I'm very interested in getting to know them, in meeting them.
Yeah,
No?
I know only a handful of people who kind of, do the consultation with like, especially the LVADs and stuff like that. So not very many that I know of.
Yes, here too, same here.
Yeah. All right, well, we're about at the top of the hour, so I'd like to just thank you for being here and for presenting today. We really appreciate you taking the time to do that for us.
I was very happy to deliver the speech. Very happy to meet you.
Yeah, it was very nice to meet you too. And I want to go ahead and let all our attendees know that we're going to have another seminar. It'll be next week on Halloween at 4 p.m. And we're going to hear about developing collaborative supervision with BIPOC trainees. So join us again then. And thank you all for being here today.
Thank you.